Hello, and welcome to the Surgical Site Infection, a Surgeon's Perspective webinar and conference call. My name is Maisha. I will be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question and answer session. Please note that this conference is being recorded. I will now turn the call over to Ellen DePratt. You may begin.
Hello, everybody. My name is Ellen DePratt, and I work out of the state of Nevada for Health Insight, and it is our pleasure to be hosting this presentation for today. So I wanted to introduce our speaker. Dr. Ren Yu Zhang hails from the East Coast. He graduated from the University of Rochester with majors in engineering and developmental biology. He then went on to earn his medical degree at Rochester School of Medicine and Dentistry. He completed his surgery training at Strong Memorial Hospital and spent a year of fellowship in research at Cleveland Clinic, focusing on surgical outcomes. His research projects were presented at various national conferences. He completed a fellowship training in colorectal surgery in 2010 at St. Vincent Health System in Erie, Pennsylvania. He's published in peer-reviewed journals, abstracts, book chapters, and numerous poster presentations. So it is our pleasure to turn this over to Dr. Zhang.
Hi, this is Ren Yu Zhang. Thank you very much for the introduction. I am a colorectal surgeon practicing in Las Vegas. I finished medical school in 2003, and this is like the 11th year being practicing, and residency and practicing. So I'm sure most of you listening who has more experience in OR than I have been through my training and my practice. As the topic says here, it's a surgeon's perspective. It's a young surgeon's perspective. It's how I observe in the OR and around me and see how we deal with surgical site infections. So I'm sure many of you have more insight and more knowledge about surgical site infections. So if I repeat something that's kind of obvious or you have questions, then feel free to let me know. We'll go through the topic, and every talk has to go through epidemiology, surgical site infection. It's 60 million operative procedures in 2010 in the United States. Overall, we're looking about almost 2% of the procedures could have infection. It does account to one-third of healthcare-associated infections. And with every surgical infection, it leads further morbidity and mortality, and it's a huge economic burden. Some people have done study an easy wound infection can increase the cost in the 200,000 range per incident. The approach for the surgical site infection, prevention of surgical site infection is really a team approach. And just like this cartoon said, it's an elephant. Everybody's looking at different perspectives. We all look at our own silos. We have surgeons. We have the hospital infectious control. We have pharmacies. We have wound care team. We have the patient. We all look at it, and we have to have a team approach to address this issue. Otherwise, we are all working at a little aspect and not seeing a big picture. Wound classification is classified as a clean, contaminant, contaminant, dirty, infected. We all know that. As we expected, as the classification go from clean to dirty, there's an increase of wound infection, and the wound infection can be superficial versus deep. From surgical perspective, what can we do to decrease the wound infection? I break down to 4 aspects. There's a pre-op aspect, intraoperatively, postoperatively, and administrative intervention. Pre-operatively, we have talked about bowel prep, diabetic sugar control, nutritional supplement, even showers. Intraoperatively, what the surgeon can do: hair removal, skin prep, antibiotic usage, body temperature, and a thing called carbohydrate loading. And post-operatively is what kind of dressing we use. Do we use a drain? I'll use a drain. Administrative intervention is all about the disclosure, the database, outcome being available to the public. Let's talk about the pre-op bowel prep. One of the thing I found on the article is they say we practice medicine with tradition against scientific evidence, and that's a very good description of bowel prep. There are different types of bowel prep. We have a mechanical prep, we have the nickel prep, we have people with the Miralax prep or Go Lightly, all different kind of prep. Overall, there has been studies showing there's an increased trend of surgical site infection with the bowel prep. There are some studies showing there's no difference between the bowel prep patient, and there is studies showing there's an increase of wound infection. However, there's no study shows that with bowel prep it decreased the wound infection. So there is a good amount of the study, and I think I have a slide in there, and to show that bowel prep does not decrease the wound infection. However, we still lots of surgeons practicing with the bowel prep, and you can see all these subgroup analysis, leaks of anastomosis, overall mortality, peritonitis, and there's no showing bowel prep is not better. So why do we still do it? One of them is tradition. Surgery is a very tradition-based practice. We always being taught this is from the down of the ages, and that's how we do it, and that's why we do it. So if the person is taught to use a bowel prep, they are just comfortable using it, and that's why we have tradition. The other one is ease of bowel handling. Obviously, when you have a colon that's full of stool, it's a little bit harder to manipulate versus a colon that's empty. And these are a very subjective measure for the surgeon, the operators, that's never captured in the actual studies, in these objective parameters. And so ease of bowel handling definitely makes a difference for the surgeon, and some surgeons like to do bowel prep beforehand. And the other thing is ability to pass a stapling device, especially for low rectal anastomosis. We typically do an EDA stapler that's passing through the anus up to the rectal stump. And if the person has retained stool in the rectal stump, it's going to be very hard to pass that thing up. And we typically have to do proctoscope or flexible sigmoid scope to remove that piece of stool or fecal matters. So with no stool in there and having a bowel prep, it's just easier to pass the stapling. The other thing we have to worry about is these studies are all done in elective patients, people with colon polyp or cancer. But with people with emergency surgery or people with obstructive symptoms, there are never any studies to show that. And there are caution against extrapolating these information onto the emergency/obstructive symptoms. The reason being is emergency surgery, typically these people had issues and they have bacteriostasis, just like obstructive things. The stool is being there for a while. They are somewhat septic. There's a bacterial translocation. So their bacterial load in their body is somewhat different from a person electively coming in from home. And the thought process is they are a little bit pre-septic before the surgery. So without a bowel prep, it's going to be different. However, with people with obstructive symptoms, you cannot bowel prep them, and they have distension of the colon with bacterial translocation, and that will give them a higher complication rate overall, including surgical sites. So you cannot extrapolate the regular study onto obstructive patients. Personally, I still do the bowel prep on all my patients, even though I have been to many lectures and journal clubs, but I still do the bowel prep, and I have to say that I'm not follow up my practice on scientific evidence. The other thing we can do at diabetic control, which I find is really hard in arthritis because we're very fragmented, is the diabetic control before the surgery. Study has shown that diabetes blood sugar control is very helpful. There's an ample study out there showing that for cardiac surgery, if you can have blood sugar control, that will decrease the external wound infection, decrease all the post-op complications. Right now, there's a pendulum swinging, go from very tight blood sugar control, go to the other extreme. Some people advocating the blood sugar should be kept between 140 to 180, and you will see other people who even want their blood sugar less than 120. One thing I noticed in my hospital, I heard is there is going to be a device coming out shortly called Intraoperative continuous blood sugar monitoring. It's a probe placed into the A-line, and you can monitor the blood sugar continuously, as opposed to right now you get one blood sugar check before you go to the OR, and then you get one maybe intraoperative, if it's a long case, and you get another one which has postoperatively. So if you have a patient, you do all the surgery, and then they hit the PACU, and you check their blood sugar, it was, oh my goodness, 250, and then you call someone, and then they give you insulin. But the entire duration of surgery, an hour and a half to 2 hours, this person could still be hyperglycemic, and with hyperglycemia, there would be a problem with infection. So if it's truly that device going to come out, I think it's going to help us a lot, and I'm sure Medicare is going to have another new guideline coming down that we have to have tighter control. And then we all know blood sugar control is there's a transient instantaneous factor, and there's a long-term factor, which is hemoglobin A1C. Hemoglobin A1C is a correlation of how good blood sugar control is in the past 3 months. There are studies showing that if you can keep if you have the hemoglobin A1C above 7.5 in a hernia repair patient, the hernia repair recurrence will be higher if the hemoglobin A1C is above 7.5. So in some centers, like Center of Excellence out there, I think in Seattle and Washington, D.C., they actually see the patient electively for surgery, and then they actually have the patient go see a diabetic control person. They typically don't schedule elective, or their goal is not to schedule elective surgery until the hemoglobin A1C is less than 8.0. This way they can minimize the infectious complication. Obviously, obesity, BMI over 50 increase infection, and I don't think we need to go in detail on that. Nutrition. Study has shown, I think the Sentinel study people quote is the VA study. They look at people with postoperative complications, and they look at multi-variables, and the only parameter that came down is albumin. If you have albumin number above 3.0 above surgery, the complication rate is lower. If you have albumin level less than 3.0, typically 2.3 is the number we use in surgery, you will have increase of complication. This is only for elective patient coming in. If the patient is being in the hospital for a long period of time, the albumin number is not useful due to all the IV fluid we give and all the meds we give. In that situation, we can sometimes use pre-albumin as a surrogate of albumin. But for people with elective surgery coming in, it will sometimes advantageous to have them have albumin above 3.0. Again, that's a team approach. The hospital, the infection team, the nutrition, and the surgeon, and the patient all have to work together. And one way to do it is have the patient to go see a dietitian before the surgery and talk about what's a good way to do a nutritional tune-up. The other way to do it, some people recommend to do 5 days of fish oil intake before the surgery and just load up on those nutritional factors, and that will sometimes help people decrease the infection. Shower. There's a study out there showing that if you give people this medication, mupirocin, and they shower with mupirocin 5 days, every day continuously with the mupirocin pre-op, that will actually decrease the bacterial skin flora, and that will actually decrease the infection. The study is not being done, it's not a subject being studied very widely, and hasn't gone through many rigorous study. However, the recommendation, people recommending is saying that this is really cheap. It adds very little cost to the healthcare system, so we can pretty much tell all our patients to do it before surgery without adding extreme amount of cost to the health system, and if that can decrease the complications, that will be very helpful. Intraoperative hair removal. Study has shown that shaving the hair before surgery increases the wound infection, so I think there are hospitals out there that actually has posters on the wall say no shave and take the shaver out, and the recommendation is use electrical clippers, doing just no more shavings. And in the Vegas area, I see a universal adoption of electrical clippers. There's no people shaving patient anymore right before the surgery. Skin prep. What kind of prep do we use for our patient? A characteristic of prep, it should be a fast-acting. You obviously can't have a surgeon wait for half an hour for the prep to take effect. And surgeons tend to put a thing on, let's go, and pushing everyone. So it'd be nice to have a fast-acting. And then persistent and cumulative actions that You will be there for a while because surgery, you can have a quick surgery, 10-15 minutes. You can have 4 or 5 hour surgery. So the skin prep will be nice to have a persistent cumulative, and also non-irritating. Non-irritating, then you have to look at most of them are skin prep, but occasionally for a patient of mine, they have ostomy, there's a mucosa involved, so you want to make sure that's not going to be irritating the mucosa. Traditionally, there's a betadine B&B prep, scrub and wash. Betadine is good because it does not irritate the mucosa. However, the study has shown the B&B prep is not as good as the new ones like Preoperative, Duroprep, and the study has done multiple studies let me see if there's a slide on that. No, there's no slide. The study has done to look at different prep, and they're pretty good. And the most important thing is actually the alcohol content in there. The alcohol evaporates down and kills the bacteria. So as long as you have a good alcohol applied on the skin, that will kill the bacteria. And then they put other mixer in there to make it. You can actually see it, or you can actually know or smell it and know how long it takes. The important thing you all probably know is you have to wait for the alcohol to evaporate, so you got to wait for 2 minutes. You can't just prep it and then get onto it. The downside of this is it's alcohol, so it's flammable, so if you go too quick, it can actually cause a combustion in the OR, which become a bigger issue. And then there's variation of usage in the OR. Some surgeons use it, some surgeons don't. Some hospital requires to use it. But if you're required to use it and you have a colostomy takedown, and you can't really use alcohol in the mucosa, so it gets a little bit harder to actually apply in every hospital. And some surgeons, again, clinicians just don't want to try anything else. The other thing I was recently being approached by infectious control people is they say, well, there's good studies of using the Duroprep or Chloroprep on the skin. They asked me to try it out to put these prep into abdominal irrigation and to see if that can decrease intra-abdominal infection. I'm kind of I haven't jumped on the ship yet because I'm waiting for more studies out there. I'm never a trailblazer, but I think people are pushing more and more of application of these prep right now. Antibiotic, that's a strict requirement. There's a timing, the selection, and duration, and dosage. Timing, the antibiotic timing, preferably, not preferably actually, I think the Medicare requirement is within 1 hour prior to the surgical infusion, and it really depends on how every place is practiced. When I train on the East Coast, the way we do is actually the OR nurse will hold it, and they will give to the patient as we make incision. Where I practice right now, the patient has antibiotic by the bedside, and when they arrive in the OR, the anesthesia will start giving antibiotics, and then followed by induction of the anesthesia, and then line placement, patient position, Foley, prep, all these things. And then at that time, we're very close to an hour mark. It's 40 minutes, 50 minutes already expired. So we have a rush to make incision, and we have to make incision to be within that 1 hour mark. Otherwise, we fall asleep, we're all in trouble. So occasionally, sometimes that falls the mark. So that is not a very good practice right now. And I think ideally it should be, they say, the last drop of the infusion of antibiotics should just go in as a person making the incision. So this way you have the highest amount of the serum antibiotic level in the serum. So that will be most useful to prevent the surgical site infection. So a good way to do it is have the OR nurse hold on to the antibiotic, and you can start the infusion as you're doing the surgical timeout. And this way, when you finish timeout and surgeons will adjust their drapes and things, and by the time making incision, that's when the antibiotic infusion finishes. And it's kind of hard in Vegas because in Vegas the antibiotics given to the anesthesiologist, and they just have to get it out of the way. So I have to talk to my anesthesia to hold on to it. The other thing I find it's harder sometimes to follow the skip is I think it's a system issue, just like the anesthesia. For people coming in for elective surgery, usually that's not a problem because they're here and they have the bag of antibiotics by the bedside. But for people who are staying in the hospital and we do an inpatient procedure, we typically write, pre-op the person the night before NP or IV fluid, write the antibiotic on call to OR. So once that's done, because nowadays it's all computerized, the order goes on to the pharmacy machine, the robot will pick up the antibiotic and ship to the bedside, and the nurse gets it, and they're saying, oh, this is for tomorrow's OR, it's not now. So they put it in a chart, or they put it on a table, put it somewhere. And the next morning, the different shift comes in, they take the patient downstairs. Sometimes they take the antibiotic with it, sometimes they don't take the antibiotic with it. And then if they went down there, there's no antibiotic on the bedside, and the person went to the OR, and nobody thought about it until 15 minutes after the incision, and somebody said, where's antibiotic? And we already fall out the skip, and it become an issue. So, it's one regulatory issue. So we fall off skip, they didn't get an antibiotic, we missed the window, we get a penalty. The other thing, it's bad for the patient. So I think we have to work into a good system for each hospital about these inpatient surgeries, how we can make sure the antibiotic, which was written the night before, that will not fall through the crack when they went down for the surgery. Dosage is antibiotic one size fits all. Right now it's one bag prepared by a pharmacy. They don't see the patient. They just see a name and sticker. They send the bag up, and patient gets that bag. But obviously we talk about we need a certain level of the antibiotic. The higher the level, closer to the therapeutic level, the better the result's going to be. So if you give 2 grams of cefazolin for a patient for a little lady versus a big tall person, the certain level is different. So it's just something that the hospital system should look into, a system thing that checking the BMI, and if the BMI is over 30, you should adjust your antibiotic to a little higher dosage, and if the person is less than 30 in a normal weight, and they should just use a regular amount of antibiotics. What kind of antibiotic we use for colon surgery? You use cefotecan, cefoxitin, Zosyn, or Inves, or you can use cefazolin plus metronidazole plus flagyl. For people with allergy, that you use clindamycin, quinolone, or aminoglycoside. Again, this is a perspective of each person. From a surgeon perspective, we want a safe and cost-effective, and we'll also want a broad spectrum. I want an antibiotic as broad spectrum as possible. My colleagues in the pharmacy, they want as narrow as possible. They don't want to use a wide spectrum of antibiotic empirically, and that could breed selection. That can select bacterial resistance. But from a surgical perspective, it's nice to have a 1-dose antibiotic and recover for 24 hours. It's a battle I constantly have with the hospital. From my perspective, I like to use Inves, which is a little bit more expensive, but it's 1 dose in 24 hours. So I deal with those, I don't have to worry about it, done. As opposed to, say, NSF and flagyl. NSF is Q12, flagyl is Q8. So you want to make sure the orders are written properly, that they don't go beyond that, or somehow it didn't fall through, and then you get more than 24-hour dosage. So that's a system issue. And skip selection, and it's more like a Swiss cheese. It's a system issue that multiple holes in there can line up, and then you can have a incident that went through all the holes and go to the end and cause a problem that fall out the skip. The other skip requirement is antibiotics continue 24 hours. There's a plenty of study out there showing that there's no benefit to continue antibiotic with a person with no infection beyond 24 hours. Obviously, a person coming in with peripheral diverticulitis with abscess in there, you want to keep on an antibiotic. But for elective patient coming in, there's no benefit to go antibiotic beyond 24 hours. In fact, and we all know that beyond 24 hours, you actually put a person at higher risk of developing infection. So that, I think, everybody universally agree that 24 hours is the cutoff date. I think the problem is it's a surgeon practice. We typically write orders, or we put computer orders in there, and we tend not to put a stop date and time. We typically not specify the number and time and the dose, and that's what I think the system is very important. Like say QA hours of flagyl. So typically, the surgeon will write flagyl QA hours times 24-hour dose. However, if you get QA hours, when you hit the pack, you write QA hours times 24 hours. If they will get 24 hours free dosage, but you start the first dosage pre-op. So in reality, the person will get 4 dosage. That's beyond 24 hours. So then you have to write QA hours no more than 2 doses, and to make sure it doesn't fall out. And then if you write QA hours, most of the hospital actually has a schedule of QA hours. I think, 8 hours, Q12 is 9 o'clock in the morning, 9 o'clock at night, and QA hours is like 6 o'clock or 4 o'clock and 12 o'clock at night, or something like that. There's a particular thing. So the person come out the OR, the first dosage depends on this OR. It could be 8 o'clock in the morning. It could be 11 o'clock in the morning. So if at 11 o'clock in the morning you get QA hours, you finish the OR, you come out, and you get the next dosage, and that will become the regular hospital dosage. So what I'm saying is, because of system issues, you might end up with more than 24 hours. Right now, I think Medicare is only auditing how many doses in 24 hours the order is written, but I'm sure down the road they can actually audit the exact time was given and see if it's over 24 hours. So that's a system issue we have to look at. And that's why I keep it simple for surgeon is, make it simple. That's why I like Intraoperative. You give 1 dose, it's good for 24 hours. It's one of the drugs that's listed in the skip, and I don't have any stock in the Intraoperative company. I just find that medication is really simple. I give the patient, I'm compliant, and the patient gets the proper coverage, and it's a win-win situation. The other question is, is there a need for a redose intraoperatively? Antibiotic has a half-life. Some of them are longer half-life, some of them are shorter half-life. For the surgery, an hour and a half to 2 hours, no big deal. But if it's more than 3 to 4 hours, the serum level is already being washed out. Should we do another dosage, say 3 to 4 hours into the operation to keep the level higher? Where I train in Rochester, we actually has a hospital requirement that anything more than 3 hours surgery, they get another dosage intraoperatively to redose. But currently in Las Vegas community, I do not see any guidelines regarding the redosage for a typically long case. Body temperature. Decrease of the immune system will decrease the body temperature. When the temperature is lower, our body enzyme and cells are programmed or are made to work in particular temperature. So it increases wound infection with colder body temperature. That's why we are very aggressively to warm them, and especially for abdominal surgery, their belly's open, they have a lot of absorptive surface. That's why it's very important for us to keep the temperature up. And I think the Medicare rule is temperature has above 96.8 when they hit the recovery. However, this is a wide variety of practice in the community. Let me see the next slide. What I have been observed is there are anesthesiologists very conscious. They give IV fluid warmers, they keep the blanket on, or there are people just come out the recovery and they take a temperature and look at it. If the temperature is now 96.8 or higher, they wait for 2 seconds and take another one until they get the one that's actually above that temperature and they document it. So it's something, again, team approach. Everybody has to buy into it and make sure we are doing the things that actually benefit the patient, not just hit the mark on the skip sheet. What kind of things we can do, and patient come to the hospital, the first thing they come in checking, they get a coat taken off, they have a little gown on them, and I see in more and more hospitals, you're having individual warming gowns. They have a little beer hugger, individual beer hugger goes on the patient, keeps them warm during the pre-op time, waiting for the surgery to happen. I think that's very helpful. The other thing is warming the operating room. Surgeons, we like to keep the room down because we're all gowned up and the light's on us, and I'm stressed, I'm sweating, and I like to keep the room cooler so I feel better. However, the patient, the belly's open, they're losing water, so the surgeon just has to be aware that, the patient is more important than us. We have to strike a balance. Warming the operating table, there are different ways of warming it. There are a warm water blanket, that's a warm water blanket under the patient that circulates the warm water that keeps the patient warm. There are huggers on upper body and lower body. The other thing is IV fluid. The IV fluid is taken out of the room temperature and infused into the body. That's 23 degrees versus 37 degrees. So the IV fluid needs to be warmed. There are devices being sold out there that actually called the hot outline, and they have little box with IV fluid going through, and they try to warm it. And you think about it, 1 liter of fluid, and you have that segment of being warm is only 25 cc, so how much are you actually warming it? It's more like a marketing thing. The best way I see most of the hospital do is just keep the IV fluid in the warmer, and then when you grab out, and this way the fluid is warmer, so it doesn't lose too much of the temperature as it goes into the body. The other thing is irrigation, and irrigation could be room temperature, and you pour in the body, it can decrease the body temperature a lot. And I prefer my scrub has a warm back warming basin there with temperature, the setting to keep my irrigation warm. And where one hospital I trained, they actually went out of their way. They bought thermometers and they sterilize those thermometers and they put into the irrigation basin, and they monitor the temperature before we actually pour it. So every case, when they open a pack, they have a warming basin and they put a thermometer in there. And so this way, the surgeon and the circulator can both look at it, what the temperature is. So it helps a lot, I think. The other thing about perioperatively is a thing called carbo loading. This is something I heard recently. The idea behind it is, again, it's back to the insulin and blood sugar. As people develop insulin resistance, when the carbohydrate storage is depleted, the increase of insulin resistance leads to decrease of your white blood cell function. Your white blood cell gets sluggish. We all know that. That's why we want to have good sugar control. We want to have, that's why the insulin is low. However, from down to the age of surgery is always NPO after midnight before surgery, which makes sense. You don't want to have a full stomach and go on induction and they ask to vomit and aspirate and have another complication. However, we always tell patients NPO after midnight, which is fine for a surgery at 7 o'clock in the morning. But if you have a surgery at 3 o'clock in the afternoon, you NPO them midnight the night before, they're going to have a very long period of not eating, and this, when they starve, their body glucose reserve is depleted by the body. And at this point, once they deplete their glucose, they're going to have increase of insulin resistance. And so when we do NPO patients for a long time, we basically set them up for set them up for decrease their white blood cell function and increased chance of wound infection. So there are places out there they do a thing called isotonic carbohydrate ingestion. What they do is 800 cc's of apple juice or Gatorade 8 hours before the surgery, followed by 300 cc's of the same solution 3 hours before the surgery, PO intake. 8 hours before, by the time you get to the surgery, it's pretty much 300 cc's, which is basically the co-liquid 300 cc injection 3 hours before surgery for a usual patient without any, say, gastroparesis or anything. By the time they get to the anesthesia, these 300 cc should be very little remain in the stomach, so their aspiration risk is lower. And so this way they have a little carbo loading before, their insulin is not that high, and hopefully their white blood cell is more functional, so they can decrease their infection rate. So that's some new trend out there. Skin barrier, does it help? We have used Ioban, put Ioban on a patient after Preoperative and put Ioban on it. Study has shown that using the Ioban has increase of infection for operation 1 in 4 hours. How do we make that? I think you have to look at both ways. First of all, surgery over 1 in 4 hours, regardless with or without Ioban, you will have increase of wound infection. We talked about we need to redose antibiotic, and the body temperature probably drops a lot after 4 hours. The other thing is, when do we use Ioban? When we use Ioban, we worry about there's a infection. Let's say I do a takedown colostomy. I want to use Ioban to cover up my ostomy so the bacteria doesn't leak out. So when I put the Ioban on it, it goes on nicely. Then I make a cut in the midline and violate the barrier. And then the Ioban that's covering the stoma that's going to have stuff coming out, because Ioban is water impermeable, it keeps bacteria out, but also traps the bacteria in. So at the end of the 4 hours, there's a puddle of bacteria, stool, mucus pooling over the stoma area. And when we finish the case, we'll take the Ioban off. I'm sure there's going to be spillage. So I think, that will increase the wound infection for sure. Is this something we should do differently? I don't know. I don't think there's any ever study out there to look at it. Should we cut the area of the ostomy to drain out that puddle before we take the iodine off or not? So I'm sure somebody's going to study into that. Drains. There's no data supporting the routine usage to drain the surgical wound. There's always a teaching when I go to residency is drains don't stop abscess formation. Don't just throw a draining there. However, the reason I put a draining there in this talk is I'm sure it's going to come up the market. I was recently in a hospital utilization meetings, and there's this vendor tried to sell a special drain with some special coating on it, and they say that can decrease the wound infection. And again, there's no data to support that, but I think with the Medicare pushing the skip things and look at the never event, it's going to come down the line. The best analogy I see is antibiotic-coated central line. I don't think there's any good study out there showing antibiotic-coated central line will decrease the line infection. Actually, the way to decrease line infection is number one is assess every patient to the either line, take the line out as soon as possible. Two is complete sterile technique barrier and cover the face and head when you place the lining, complete sterile technique, and lines no more than 7 days. So these are being studies shown that will decrease line infection. However, every hospital nowadays use central line is antibiotic coated because we just want to do this to show that Medicare that okay, we've done that. We do everything possible to decrease our infection. So I won't be surprised there will be suddenly a surge of antibiotic coated drains coming into us, and every hospital has spent extra money to buy those drains just to show the effort that we have done to decrease our wounds. That's something I can see on the horizon. Wound care, post-operative. How do we take care of the wound? There's a wide selection of dressing available, and there's silvers, algaes, there are permeable wound and impermeable wounds. Where I train in New York, we have cardiosurgery that's being scrutinized very closely, so every kind of dressing is being used, and the dressing is getting more and more expensive. And there was a joke that one day we're going to have, right now the silver impregnated because it's a heavy metal, it kills bacteria. The joke is maybe one day the gold impregnated, and some days the platinum impregnated, and then the dressing is going to come up, and maybe that will kill more bacteria. In Las Vegas, we typically use AVD and clean gauze, and that appears to be the norm. I can't speak for the orthopedics, but in general surgery, colorectal, clean gauze is what we have right now. Wound care, back dressing. Is back dressing helpful or not? There are people recommending short-term usage 1 or 2 days after the surgery. When the wound is closed, just put a little back dressing right over the staple line. What it does is the negative pressure sucks away edema from the wound because the wound's going to have edema, and when you take away edema, it decreases seroma formation, and this way it can decrease the wound infection. There's no evidence to support that, and it's pretty costly to do every patient, and that's pretty expensive. The other way to do it, I have seen surgeons to do is they leave their wound routinely open. Like ostomy takedown, we don't close the wound, and in the old days when you have open appendectomy, some people leave the wound open, some people do a delayed primary closure. This is something you can do in a small wound like an ostomy or appendectomy, but if you have a large incision from stem to sternum, it's going to be very uncomfortable for the patient. It's a lot of morbidity for the wound care packings, and that's pretty expensive too. So my personal experience in practice is actually put a little wick in the wound. What I do is I close the skin up, I leave a couple gaps in there, I put a little wick. Usually I put alpha in there, which is a slippery thing. I don't want the nurse to pack it. What I do is I pull the wick back over the course of several days, so this way it collapses that cavity underneath the skin so it doesn't have a dead space trapping the seroma and causing the infection, causing hematoma and infected. So that's what I do personally. Wound protector. It's very fashionable in the early 2000s. I think every surgery, I remember gastric bypass patient back then all had a wound protector that gets put in the wound, gets draped all over. Study shows there's no benefit, so in the 2000s is all kind of goes away. And now it's coming back in fashion because laparoscopic colon surgery would make small incisions. So the new wound protector actually has 2 rings on it, so you can actually stretch them out. So it serves as a retractor on top of the wound protector. And I do see a decreased amount of wound, subjective. I haven't ever done a study, but what I see is when I use a wound protector, when I extract the colon out in laparoscopic surgery, they tend to have less likely of wound infection. The other thing is the dermabound. That's not water permeable. The wound is visible. So this case, I can actually see the wound every day without taking the dressing off. I only use it in laparoscopic colon case when I have a wound protector, so there's less likely of wound contamination. The problem with dermabound is it's a non-water permeable, so it traps everything inside. So if you actually have a wound infection, it makes it worse because it can't drain out. Otherwise, you have a skin staple, it actually pops out one area and it just drains out easily. And the question is, are these impact the decrease of length of stay? There's no study on that. And the other thing is, typically wound infection manifests about 7 to 10 days after the surgery. So if you have a procedure, and now we are striving for decrease of length of stay, a colon resection, Medicare approved right colon for 3 to 4 days stay, and left colon is a 5 to 7 day stay. So if they develop a wound infection, they will develop after they get discharged. So right now we only track the wound infection in the hospital, but we don't track the wound infection in the office. So if I look at it and I can have a wound infection in my office, these numbers are not being reported. So it's a team approach. We have to work together on that. Administratively, database. There's increased trend toward database, public database, outcomes available. Everybody can look at it, look at each surgery, what their admission rate is, what their readmission is, what their post-op death is, and there's all these things. I was trained in New York City. We have a cardiosurgery database and look at every cardiosurgery program and look at, say, okay, are you above the benchmark? Are you below the benchmark? They line everybody up, and this is number 1 versus last in New York State. It's a lot of pressure on the surgeon, and it's very helpful. I think it makes the cardiosurgery a lot better in New York State. However, it does make people try to cut around the corner because one example is the external wound infection. We actually have every week we have a run to look at infection rate. What it is every wound, basically the surgeon, the wound care specialist, and the administrator has to look at it. Is this a wound or not? Is this a wound infection or not? And their surgeon argue, well, there's no pus coming out the wound, so it's not an infection, just a little redness, it's a cellulitis. Cellulitis is not reported, wound infection is reported. So it gets a little bit silly when it underreporting and affects the accuracy and the validity of the data. And but it's good as benchmark, so everybody can look at it and see how am I doing in the whole group. In Las Vegas community, it's very hard. We don't have that many. We are lack of access. We don't have that many surgeons around. And if you look at some place and only have one surgeon, how are you going to compare that one surgeon to other places? In some places, that's the only surgeon there. If you look at it and the surgeon number is low, what are you going to do? You're going to send a surgeon away, and then your hospital has no surgeon, and the ER closed, and there's no patient left there. So I think we have to look at these administrative data in the way how we can construct it to make it useful to the community and to the patient. Public disclosure. It's where I train in Pennsylvania, they passed a law. They require a hospital to disclose to the patient and the family for every complication in the hospital, such as UTI, a wound infection, or C. diff. So it's a lot of work for the hospital. Every time the people coming in is little something, and you have to send a letter. And the letter is usually, this is what happened. The patient in the hospital, they did fine, they went home. And the chart went to the coding department, the coding department finished their part, and then went to the compliance department. Compliance department went through it and say, oh, there it is, there's a UTI in their document, so we got to send a letter to the family. That's several months after the event. And obviously it's coming from the administration, so the letter is approved by the lawyer. It's very blank. Just say, during a recent stay in our facility, there was an adverse event happened to you. And if you need further information, we'll be happy to talk to you. And most of the family gets home, they had their hospitalization, they were happy with it, they went home. Doctor probably explained to them that there's a UTI, you need to go home, there's no extra antibiotic, and they're home, and 3 months later, they get this letter from the compliance office saying there was an adverse event. and it gets caused lots of confusion. They call their doctor, say what happened there, what's going on, I was at danger, and cause lots of confusion and the unnecessary anxiety in the patient and family. So the law was a very good idea that we had to disclose everything to the patient, but in the reality, the unintended consequence that I have one surgeon that left every wound open, elective colon resection. This way, he said, I will never have a wound infection. I don't have to report to anyone. So in conclusion, and I went through these real quick, again, this is a perspective from a young surgeon, and obviously my experience is not as good as yours, and I only have my perspective, and this is a team approach. We all have to look at it from our perspective and try to make it together working. Education plays a major role because you can't just come in and tell a person you got to do this. I have one hospital, they have one person at the OR door, and every surgeon walk by, they say, today we're going to start using a prep. And the surgeon is like, no, I've been here for 10, 15 years. I'm using my prep. Education, communication is very important. Exchange of idea locally and nationally. We talk about all these things. Every state has a center of excellence, and that's what we talk about. We get together to talk about it. So I think that's the end of my slide.
Maisha, are we back on, or yes, would you like to go for the question and answer portion at this time? Yes. All right. We will now begin the question and answer session. If you have a question, please press star, then 1 on your touch-tone phone. If you wish to be removed from the queue, please press the pound sign or hash key. If you are using a speakerphone, you may need to pick up your handset first before pressing the numbers. Once again, if you have a question or comment, that is star, then 1 on your touch-tone phone. We are now standing by for any questions.
Before we go to that, I see there's a chat part in there and that people already have questions there. You want to just address those questions first?
Yes, sure.
So from Pat, and it says fish oil increases the risk of bleeding. Yes, fish oil does increase the risk of bleeding. Again, this is a team approach, and we have to look at every aspect. I think you can there's no magic bullet out there, that one thing that does everything. And it's just a perspective, and fish oil can increase can boost up your nutritional status a little bit, your lipid level, but it can also have some side effect. And this is just something you have to think about. Is this something worthwhile to do it? And I think you can talk with your surgeon to see, is this worthwhile to do it? And that's why these things like a fish oil and shower, they're very cost very little to a patient in the hospital, and it's something that you can start in a low risk patient, like say patient coming in for incisional hernia repair, and let's try that, see if it works. And does it increase the risk of bleeding? I can't address on that. And then the shower part, 5-day showers and piercing, it is the easiest thing I've had in my experience in my training day is we actually use the CHG, the scrub things for the hand, the scrub, what I'm talking about, the OR scrub thing. The package is a little hand pick, the nail pick, and a little brush. We actually, where I train in New York State, we for the cardiac patient, we actually give them 5 packs and they just take it home to use that to showers 2 to 5 days before the surgery. And this is what we do. It's a lot easier than actually go to the pharmacy and buy things. So yeah, you can have them in elective cases to take these home. Again, this is, I think, is a team approach. You have to have your surgeon buy into it. You have your hospital buy into it. One way you can do, like we did in New York, is in the pre-op visit in the office, we actually give them 2 to 5 packs, depending on the surgeon, and the patient will take the shower and do the scrub at home 2 nights to 5 nights before the surgery. And here you can do the pre-op registration. You can give them that as something we can do. So that's the question for Cindy, and for I think Pat had a question about how dosage requirement recently changed. We're still going with a 1 gram versus 2 gram weight-based. I think it could depend on every hospital. There are, again, different. That's why we should do exchange of idea locally, nationally. Some hospitals do 1 to 2 grams, some hospitals do 2 to 3 grams. And the idea is you just can't do one dosage only for every patient walks through the door. You have to have individualized parameters. It's not one size fits all. What study shows fish oil is effective in improving the nutritional value and preventing infection? There is a study, I can't give you the name. I learned this in a conference recently. It was done in Seattle. They have a center of excellence in hernia repair, and they have looked at their patients and with fish oil that actually has decreased the wound infection. These studies are not very rigorously done studies again, but there's just little things that put out as again, it's very cheap. It doesn't cost that much, and if it can have an added benefit to the patient, it might be. It doesn't hurt much to give it a try. The study shows a decrease in infection albumin of 3. That's a study I think was done in 1980. It was a Veterans Affairs VA study done back then. They actually looked at wound infection and post-op complication rate. They looked at a large population because the VA you keep track of all these data. It was a study that's always being quoted, and I don't have the number. I don't have the exact titles. And they look at multiple variables, and they find out it's the albumin level less than 2.3 has increased complication, and more than 3 has less complication. The study is being criticized. There are multiple criticisms about the study. One is, again, it's a VA study, so the population is very homogeneous. Caucasian male and in the late in their age. And the study, they always question how good these VA patients are. They have more comorbidity. There's sometimes more patients with cardiovascular disease, peripheral vascular disease. Do you look at these? Even though the study didn't show any difference, people criticize about that. The other thing people criticize is it has never been replicated in other places, but to have a large study like this is going to be very costly, so it's never been done. And I think the correlate of that study is they actually went into the next study to look at nutritional supplement. And only the next study shows is only 7 days of pre-op PPNs will help you to improve your outcomes. And if PPN 1 in 7 days is actually increase the complication. That's why, surgeons want PPN 7 days, no more than 7 days, and some days they just want 7 days of tune-up. The problem with that study is I think it was done for patients with gastric cancer at that time, so the people cannot eat. So it's a very specific group, and they try to extrapolate into the general population. Again, these are my perspective. It's not like a full scientific study. The PEG to our participant, I think CHE is the answer to start with. Definitely, what did you say you were using with the download irrigation? This is something I got into the hallway that I have an infectious lady come to me and say, hey, can you use for your download irrigation when you at the end of case you irrigate your abdomen? Can you use DuraPrep as your irrigation? And because DuraPrep has been shown to kill all the bacteria, why don't you use DuraPrep? And I was like, I don't know, lady. That's kind of pushing the envelope. And the reason I don't like to use DuraPrep intraoperatively is because, one, there's no study. Two is there's no guideline to it. The three is that I don't know if DuraPrep applies because DuraPrep is all geared toward the skin flora. And intra-abdominal flora, it's spillage from the colon could be different flora, could be different bacteria. So is the coverage, the spectrum is right. So I was reluctant to use that. I'm just using normal saline right now. I don't use GU irrigation routinely. Sharon, the shower, we cover that. The fattest smoking thing. Have you considered novel dosing strategy of preoperative antibiotic to promote ease of administration? Supplemental compound, electronic infusion over 30 minutes, no need to repeat dosing, and only one intraoperative redose of supplement is needed to serve for universal medicine. Yes, talk about what to do, I think, there's a lot of, the question is, in reality, how much antibiotic we use. Again, it's a tradition versus a scientific evidence. Because we've always been using antibiotics for the surgery, so we've been using antibiotic, and ever since antibiotic comes out, we've been using it for the surgery, and I think antibiotic has come out, penicillin in the 1940s. So for 70 years, we've been using these antibiotics, and at this point, we finally educated all the surgeons that no need to give antibiotic beyond 24 hours. So, I'm sure 30 years ago when a person get a surgery, they get antibiotic for the next 14, 20 days in the hospital. And now we finally convince majority of surgeons 24 hours is all you need. You don't need to go anything beyond that. And I don't know if anyone's study out there, and I won't be surprised somebody's going to have a study coming out and say, hey, 12 hours is as good as 24 hours, so you don't need to do anything like that. So for pre-op strategy, I think infuse over 30 minutes. The normal technique, over 30 minutes, you want to do over 30 minutes to be really slow, so it goes in a steady state, as opposed to right now, my anesthesia is just saying it, everything runs in there in 5 minutes. However, if you do 30 minutes, my concern is, it's a team approach. Everybody has to buy into it, and it requires a lot of coordination among the surgeon, the anesthesia, the circulating nurse to make sure it is going in there for 30 minutes, and when it's finishing infusion, it's within an hour of incision, so it falls within the skip criteria. Otherwise, if you fall outside skip criteria, you're going to be in trouble. The ertapenem, universal use, yes, ertapenem can breed resistant bacteria. That's why the infectious disease doctors and pharmacies don't like to use it. Again, surgeon's perspective is we want a wide spectrum, as wide as possible, if hopefully cover everything in the world, one dose to be done. However, it does breed resistance, and we have to have a balance between these two. The way I look at it is a hospital has two people against using ertapenem. One is the pharmacy because it is very expensive. Number two is infectious disease, the control infectious disease doctors. They don't like it because theoretically I can increase the resistance. I'm not an infectious disease person, and I don't look at my bacterial resistance chart every month, and I'm sure every hospital still keeps track of that bacterial microgram. However, there has never been a study to show that wide usage of Invans in the pre-op setting has altered the hospital community and nosocomial bacteria resistant chart. So that's a theoretical concern, but we don't have that documented any places. Not saying it's not going to happen, but I don't have any evidence to show that universal usage of Invans will breed resistance in your individual hospital. It's just
okay, Dr. Zhang, we're getting close to the end. And Maisha, are there any questions that are on the phone?
Ladies and gentlemen, if you have an audio question, it's still *1 on your touch-tone phone. We have no audio questions at this time.
Great. I did see one question in there, Dr. Zhang, that's the one that follows there about infection. What would you like an infection preventionist to do as follow-up if one of your patients had a surgical site infection? And we'll make that our last question. But how do you see your role in that? What do you want to do as a collaboration?
I think my role is very important that if I don't report, I have an infection in the hospital, I have an infection in my office. If I don't communicate to other people, then the data is now being reported up and nobody's going to look at it, and you can keep constantly doing it and not realize that you have a problem. And I'd be happy to review every case with my infectious control person and to look at do I have a train, because it will be too late, like you have suddenly 5 C. diff happening on the floor and one person gets a colectomy. That would be too late. I think, as a surgeon, we should be actively involved in infectious control to talk about it. What's the trend? What's the bacteria resistant in this hospital? what's my usage and what's my number of falling out of the charts. And I think, it's important to have surgeons to be on the infection control committee to look at it, because infection is more than just giving an antibiotic. It's about surgical technique, about their surgery, how they select a patient, prepare the patient. So I think it's very important. I think, like outpatient clinic, they have outpatient surgical center, they send me a letter. I have to check. I did a procedure there. Is there any complication? Is there any patient end up in the emergency room afterwards? I have to report that. And the same thing is the hospital should have a thing. A hospital call the patient, say, hey, you were just discharged from hospital 2 days ago. I'm just calling to make sure you're okay. I think the hospital should also call in the surgeon and talk to me, say, is there any other problems? Like, is there a wound infection? Is there any follow-up? And is there your patient care gets properly? So there's a exchange of information will be very helpful.
Well, I want to thank Dr. Zhang very much, and I did see a poll pop up on our screen, so please do those. And we appreciate all of you coming along. And Maisha, any closing remarks on your end?
I'd like to thank you, ladies and gentlemen, for attending today's conference. This concludes today's conference. Thank you all for participating. You may now disconnect.